oftentimes we're coming in with sicker patients, frail patients. You've got to really look at the whole picture here. And so let's just say you're going forth for a TURBT, whether they've had any extensive imaging or not, MRIs plus or minus. What are your goals of that TURBT?
Yeah, I think when you go in, the goals are complete resection. There are two reasons for that. One is you want adequate tissue, and I think if you have a large tumor, you often get adequate tissue to make a diagnosis. Look for variant histology. But also, I tell the residents, we're not sure this patient's going to go for a radical cystectomy. And if they choose chemoradiation or TMT, part of that TMT is going to be maximal resection. So you should probably aim to do that in the very beginning so that if the patient chooses TMT, then you're sort of already set up for it. I'm not sure there's enough evidence that doing a maximal TUR will render the patient or increase the chances of having T0 on final if you get neoadjuvant chemotherapy. I know there's some retrospective data, but I wonder if that's just a selection bias of the patients who are getting sort of maximal resection by virtue of their tumor being smaller. So I certainly don't think it hurts. I think the data is sort of going towards better responses. And I certainly don't think that doing extensive TURs leads to metastases. There's tons of circulating tumor cells seen after TURs. It's interestingly, I don't think they land anywhere or lead to metastases. So my goal is always to do as good a resection as possible, to have as much information as possible, potentially help with both neoadjuvant chemotherapy or TMT if the patient so chooses.
Yeah, wholeheartedly agree. And I think it is always something to at least consider. At the end of the day, let's say you get neoadjuvant chemotherapy and a cystectomy and you wind up being T0, you're pretty much, should be home free for all practical purposes. What are the contributions of surgery in that and what are the contributions of chemotherapy? Likely impossible to know without some marker lesion studies, which are probably not really warranted, but, something to think about. And in an effort to get a complete resection, do you use blue light enhancement on your initial TURs typically?
Yeah, good question. I do. We have the luxury of having it widely available to us, both in the clinic and in the OR. I think it helps in multiple ways. One is, as you said, to see the edges of the tumors, even if it's going to be muscle invasive. We do a better TUR. We see whether or not there's CIS and resect that. And also for training purposes, I think that the residents really get a lot of feedback when they've done the TUR and sort of turn on the blue light and say, wow, I missed that corner, even though I went wide in that area. And plus we don't always know whether or not it's going to be muscle invasive. Sometimes you go in and you say, oh, absolutely. You've done thousands of these and you say, this is absolutely muscle invasive. And it comes back T1, right? And so I tend to use it whenever I can. Now, when I have a really nasty tumor and it's not going to be helpful, I'm not going to do a maximal TUR in a 7 centimeter tumor. The obvious sort of tumors, I don't do blue light there. But if it's a smaller one and I'm not 100% sure it's muscle invasive, absolutely.